Okay. Welcome, everyone. If you want to introduce yourself in the chat, we're going to get started in a few moments. Um, right on the dot at 1, we have a lot to get through today with our lovely panelists attending. For those of you who are attending live, like I said, go ahead and put your name in the chat just so that we know who's there. And yeah, we'll get started in a few moments. Oh. Alrighty, so I'm going to start making introductions as well as pulling up our PowerPoint so that you kind of start logging in and looking at what's going on. Alrighty. So everybody, welcome to Mix It Up. I just have the QR code right here for the All of Us research program. As some quick housekeeping, our schedule for today is going to be a brief presentation on All of Us, our speaker presentations, and then a good amount of time for Q&A. I will introduce each speaker, their association, and describe them briefly as they put up their slides or just start talking. Feel free to use the Q&A function throughout the event, but we'll only be answering those questions in the last 5 to 10 minutes at the end. If you have any tech issues, you can private message me, Morris, and my pronouns, by the way, I use any, or Megan Garmello, she, her on Zoom. With that said, let me do a really brief introduction for each of our speakers. So first off, Dr. Jessica Elm is with All of Us, the program who has fortunately partnered with us today to present this. Devin Anderson and Dr. Jacob Dish with the American Association on Health and Disability are here today. And we also have Donna Dill with Mobilize Waco. We are Waco AHEC, by the way, the Area Health Education Center, and are located in the Waco area, though our service region expands into all of Central Texas. Also joined today, like I said, is Megan Garmello, my coworker, as well as Ashley Bearden, our executive director here at Waco AHEC. I will be moderating today, so like I said, if you have any questions, feel free to message me or Megan. So this Mix It Up's theme is disability. We have the disability pride flag in the background, as well as these symbols for each of us. Just some quick acknowledgements. The All of Us research program is partnered with us as an engagement partner. We have our award information, our outreach information on the top, just so that you kind of understand the relationship between our two organizations, right? So we want to make sure that y'all know that we're here to promote All of Us, as well as to provide information. The All of Us research program, just a very brief overview since Dr. Elm is a research ambassador, is a part of the Department of Health and Human Services. We are funded through the National Institute of Health, and our goal is to get 1 million or more Americans enrolled in a huge variety of research for the goal of pursuing precision medicine. So obviously, we're going to be discussing this a lot more, but that's kind of it for our quick presentation today. With that being said, we are now going to move on to Dr. Elm's discussion today. So once again, just a brief reintroduction of who she is. Dr. Elm is a research ambassador, meaning that she works with the All of Us program to both use their data and to encourage others to use it as well on the research side. So any students in the audience, if y'all have ever been interested in pursuing research, keep it in mind. this person is very successful in this realm, and we definitely want to learn all that you can from it, right? So Dr. Jessica Elm, MSW and PhD, is a citizen of the Oneida Nation, descendant of the Stockbridge-Munsee Band of the Mohicans, health and social scientist, and president and owner of Like the Tree Consulting, LLC. Dr. Elm received her PhD from the University of Washington in 2018 and her MSW from UC Berkeley in 2009. She was trained and employed at Johns Hopkins School of Public Health, and a significant aspect of Dr. Elm's research training was focused on community-based participatory research methodologies. In addition to advancing her scholarship, Dr. Elm leverages her collective work prior experience working with tribal communities to deliver tailored services and products to tribal nations and organizations. Dr. Elm has worked in a large range of capacities and with various stakeholders from local, state, federal, and tribal governments and communities. She has served as a direct service provider, social worker, project manager, behavioral health administrator, legislative assistant, program and strategic planner, and a diversity, equity, and inclusion advisor. Thank you so much for joining us today, Dr. Elm. And with that being said, take it away. We're so interested to learn what you have to say today.
Thank you so much for the introduction. I appreciate it. So I'm going to, I just have a few slides that go over the study just to kind of situate us all, so we're all on the same page. I know that probably some of you are familiar with the All of Us program, so I don't want to go too deep into it, but I kind of want to just highlight some key aspects of the program. And so I won't reintroduce myself, but this is the starting slide, and you already showed this other lovely slide, so I'll skip that one too. So just to go over the mission really quickly about All of Us. The mission is to accelerate health, research, and medical breakthroughs, enabling individualized prevention, treatment, and care for all of us. And so the key takeaway here is really about individualized treatment, so precision medicine, in other words. And so the other aspects of this really involve building partnerships, which is sort of, what my participation is in the overall program. And then here it says catalyzing an ecosystem of communities, researchers, and funders. And so I'm going to touch upon the researchers aspect of this in a few minutes. And then, of course, to deliver one of the largest data sets that is usable by a variety of researchers. And so just to recap, the goal is to invite and enroll over 1 million participants. And as of about last week, there's over 785,000 participants enrolled in the study. And among these is 87% of the participants identify with communities who have been underrepresented previously in biomedical research. And so this is really a key driver, a key point to take home with you, is that this study is really remarkable in that way, because there's so much that we don't know about marginalized populations in the biomedical research area. And then also 46% of the participants are from racial and ethnic minority groups. So, a lot of people talk about the All of Us study from a biological perspective, and some would say that the genetics part is, a great part of the study. But I'm a social scientist, and I really care about what happens to us in our lives that impacts our health and well-being. And there are interactions, so it's not one or the other that impacts our health. Often the social environment can affect how our genes express themselves. So this is really an opportunity to have a large data set that has representation of different types of life experiences from the participants. So this is the reason that I, as an individual researcher, find the study to be interesting. And others probably, we could have a lovely debate about that, but I think it's the intersection that really is meaningful to the research, driving research. And so I just wanted to share this slide. It's a little bit older, so the numbers are not precise, but I wanted to share also that the study really covers a lot of different areas, including they added some COVID-related measures or surveys. And so it's not a static type of study. They're trying to fold in different types of data collection as time goes by. But also here in the middle, you can see some of the topics covered. It talks about stress, resilience, and those are the two areas that I study in my work. And then things like loneliness and vaccine perception. So it's very expansive, as you can see. And then another area that was expanded upon during COVID was mental health, which is another part of my research. And so I just wanted to, again, just emphasize that the study is very diverse in multiple types of ways, including expanding the types of data that's being collected over time. And this is just another lovely image of what we like to call social determinants of health. And these are the social and environmental factors that influence our health. Everything from, what neighborhood do we live in? Do we have access to things that in our languages that we speak? Do we have access to other types of resources and things like food security? Are we able to practice or be ourselves in the places that we move and live in? And so I'm going to shift now. That was just a very broad overview, and we can talk more about the study during the Q&A, but wanted to shift now into the part that is about sort of encouraging researchers to think about using this data set within their own work. And so that's the other part of the All of Us research program. That is the part that I fit into. I'm not necessarily out being an ambassador to try to recruit individual participants into the study. I'm more of just having conversations with researchers to think about or talk about what it might be like to use the data set. And so these are the kind of pillars of how we try to encourage researchers to use the data set. And I'll expand upon here in a minute why I am being careful about my words, because there's some data issues that are unique to American Indians and Alaska Natives. So I am walking sort of a fine line of recruitment isn't really quite the right word, but having discussions and opening things up to hearing what people want to say about the data set and just having honest conversations. So again, another part of the program is to recruit researchers from diverse backgrounds. So oftentimes so I'm an American Indian female, and I have multiple disabilities as well. And so my unique perspective looking at the data, I will be able to interpret and talk about the data in a different way compared to somebody that doesn't have that lived experience. And so we really want to make sure that we can have those different types of perspectives and voices that are looking at the data and analyzing and interpreting the data. And I'll just highlight a couple parts of the data access piece, which is that there are over 440 academic institutions that are now involved with the study and various other institutions. I understand that they're going to be expanding even to international institutions will have access to the data pretty soon as well. And this just maps out sort of the process of participants, from the participant engagement, sharing their data, and then all the way through how research is interpreted and disseminated. So it starts with, of course, the participants sharing their information and their data. That includes, again, biological data, survey data. And then also, I didn't mention this earlier, but participants who have a Fitbit can also share their Fitbit data. So once that data is gathered, the participant data is funneled into what they're calling a curation pipeline. So it's a repository that's very secure and has lots of protections in place so that the data can't be accessed inadvertently or purposefully, I guess you could say too, but there's lots of securities around this data. And so this is why researchers are asked to go through a process to even access the data. They have to make sure their institution has certain data use agreements in place. They have to go through training to access and use the data. And that's how they end up registering and then eventually interpreting and analyzing the data for publications, typically, or presentations and dissemination of information and knowledge. So I'm going to transition here just to highlight one of the other scholars that's part of the All of Us program, and this is her research. And I thought it would be interesting to show this brief slide because my research does cover discrimination and depressive symptoms, but this is not something, although this is very similar to a study I would want to do, I have not been able to do this type of study yet because of the data access issue. But I wanted to show just an example of something that would be similar to the type of research that I do. And to shift again, just very briefly, I want to share just one slide from my work that kind of gives an overall view of sort of some of the things that I have studied in the past, which is discrimination, microaggressions, lateral oppression, unemployment, and sort of just looking at the whole lived experience of a group of American Indians and Alaska Natives who had diagnosis of diabetes, type 2 diabetes. And so my work really talks also about historical events that have happened and how that has influenced the health and well-being of multiple generations of American Indians and Alaska Natives. And this really goes back to historical events and historical traumas that have occurred and led to more contemporary situations such as widespread poverty. And so now I'm going to switch back a little bit, back to All of Us real quickly. And sorry for the back and forth, but I wanted to kind of contextualize what I'm about to say now, is that, a couple minutes ago, I mentioned that I don't have access. Well, I do have access to the data, but I'm not accessing the data currently. And, you might wonder why that is. And at the very basic level or how I can explain it is that tribal nations are sovereign nations. And so rather than thinking about a racial group, if you think about what it might mean to be a sovereign group, so having a nation that has resources and they need to take care of their citizens, this is how All of Us is thinking about tribes and tribal nations. And so there's been a lot of back and forth since even before 2017 here, it shows negotiations and relationship building and trust building between sovereign nations, sovereign tribal nations, and the All of Us study in particular, in order to build that trust and in order to have that data available, hopefully in the future. So I hope that made sense. I kind of wanted to just share that because I don't actually use the data set, even though I am out here talking about using it. It's not currently in my portfolio of research. So I think I will stop there and just say thank you. And I definitely open it up to any questions that you all might have towards the end.
Awesome. Thank you so much, Dr. Elm. So thank you so much for that wrap on the All of Us research program. You went into such depth. That was wonderful. So now we're going to transition over to Jacob and Devin, who are here with the American Association on Health and Disability. Devin Anderson has been with AHAD since November of 2023, but she has worked in disability and advocacy nonprofit space for years. Having two invisible disabilities and parenting children with multiple disabilities, her experiences and passion drive her work at both AHD and in outside advocacy as well. Jacob Desch, an OTD, is a hard of hearing senior research associate for the American Association on Health and Disability, where he uses his own lived experience of disability to serve as a disability advocate and researcher. Thank you all so much for presenting today.
Thank you so much for having us. I'm sharing my screen. We have a link for you to go and visit. And then I've listed both mine and Jacob's email addresses for any future conversations down the line. So I want to start today talking about disability and how far we've come and how far we still have yet to go when it comes to our work with the All of Us research program. So disability history is marked by a legacy of discrimination, exclusion, and neglect, where disabled individuals have often been viewed through a lens of pity, charity, or mental pathology rather than as full and equal members of society. This context, unfortunately, has shaped societal attitudes and policies and practices regarding disability, which contributes to the persistent barriers in healthcare, education, employment, housing, and community participation. And the truth is that people with disabilities only gained equal rights like 30 years ago. The disability rights movement gained momentum in the mid-20th century, led to things such as the passing of the ADA, or the Americans with Disabilities Act, in 1990. And that prohibits discrimination against individuals with disabilities when it comes to things like employment, public accommodations, transportation, and communications. Despite these achievements, though, disabled individuals continue to face unique challenges when it comes to accessing healthcare services, receiving appropriate accommodations, and navigating complex healthcare systems that may not always be inclusive to the needs of the population. This historical legacy of neglect and marginalization has left a lasting impact on healthcare disparities, health outcomes, and the quality of life for those living with disabilities. Healthcare should be a basic right for everyone, but this pervasive lack of access to inclusive, accessible, and affordable healthcare is impacting those with disabilities in a large way in terms of their quality of life, while also confirms their mistrust of the medical system. And I think that is something that we see in our work. The truth is that addressing these barriers will require many approaches that involves a lot of collaboration amongst healthcare providers, policymakers, advocacy organizations, and most importantly, including the disability community itself. More organizations are working to address these complex and ongoing barriers that exclude people with disabilities from gaining proper access to healthcare. And one of those organizations is mine. The American Association on Health and Disability is a national cross-disability nonprofit dedicated to ensuring health equity and inclusion for those living with disabilities. We accomplish our mission through research, advocacy, education, policy, and knowledge translation efforts at the national, state, and community levels. Since 2018, AAHD has been supporting outreach efforts with the NIH's All of Us Research Program. We currently lead a network of 20 national and local disability groups in these efforts. And so the disability community has historically been left out of health research. And so we really want to change that with the All of Us Research Program. All of Us honors the disability movement's central mantra, which is nothing about us without us, which invites those with disabilities to contribute to research findings that may lead to more tailored healthcare in the future. In 2022, we launched our inclusion statement, which is no research about us without us, which called on the disability community itself to become a part of all of us. This statement was developed with input from people across the disability community to build a vision for inclusive health research. And in this statement, we highlight what All of Us is currently doing to engage people with disabilities and working to share best practices for accessible engagement with our communities. We also highlight our vision for inclusive health research that supports enrollment of people with disabilities across all of the spectrums, including those who may not be able to consent to participate on their own. And this year, we launched a disability and health conversation series to build awareness of some key health concerns in the disability community. This is through webinars that we are hosting on almost a monthly basis. They've been pretty successful in terms of the reach and the scope. We've talked about things like the disability and intersectionality, disability and mental health. And on April 30th, which is this coming Tuesday, we are going to be addressing long COVID and its impact on the disability community. And I have a link to share in the chat for registration for that if anyone is interested. We have an exceptional panel of people coming to talk about their experiences, both with lived experience with long COVID and also those who are doing research to help move some of that along and get more treatments in place for those who deal with long COVID. We see these conversations as ways to share a vision for disability health to help us shape what research is happening on the data workbench. And we really hope to see more studies that examine disability and the health needs that exist around it. In the end, I believe that by addressing these barriers comprehensively and adopting a person-centered approach to that healthcare, we can work to create a more accessible, equitable, and inclusive healthcare system that meets the diverse needs of all individuals, especially those living with disabilities, and that will improve health outcomes and also health research. And for that portion, I'm going to defer to my esteemed colleague, Jacob.
Hello, as Devin and others have said, my name is Jacob Ditch. I am a senior research associate here at the American Association on Health and Disability. I got started with this role after completing my clinical doctorate in occupational therapy, so I'm clinically trained. I got my training in occupational therapy, but I really felt that the healthcare system falls short, especially when it comes to the care for people with disabilities, area of research and work that's near and dear to my heart as a person with lived experience as a disability myself. So that's part of the reason why I'm doing the work I'm doing now. I do want to quickly just talk a little bit about the All of Us Research Program and the work that AHD is doing. But first, I'll describe myself a little bit. I'm a white male with facial hair, a beard and mustache with long brown hair that's tied up into a bun right now. So just as a background for a visual description of myself. As has been mentioned earlier in the panelists today, I mean, All of Us Research Program is really quite a historic and longitudinal effort for gathering data for more than 1 million people in the United States. This is something that's really quite unique in the research space. I mean, there have been tons of databases and ways to collect data from participants, but it's not quite to this level of scale. I mean, 1 million people in one research project is really quite amazing, and so this is quite a lofty goal by NIH and the All of Us Research Program. And really by doing this, it helps, look at all these different individual differences in lifestyle, socioeconomics, environment, biology, And it's really quite intersectional as well. It's not just focusing on, race and ethnicity, but it's looking at, disability, LGBTQ status, and really exploring what it means to be a part of these groups that have been seriously underrepresented in biomedical research in the past. And by focusing on these groups, we can learn a lot more about the things that will help improve the health of the lives of people who typically have experienced the highest and largest group measures of health disparities. So, a lot of this is partially the things that we see as AHG and why we're involved in this in the first place is that, as Devin mentioned, we really believe as the disability community in the mantra, nothing about us without us. And NIH has seen the value in that as well. And so we are the national community engagement partner that helps focus on engaging and reaching the disability community, both to recruit members into the All of Us research program, but also to work with disability and health researchers themselves and recruit them to use this data set. Part of that is by talking about exactly what the All of Us research program is and what it is that it wants to achieve. Our role in that is also to help with the expansion of inclusion of people with disabilities in particular, and really looking at the intersection between disability and other UBR groups. And so that's one of the things that makes the All of Us program really unique. It's a national resource for all. It's broadly accessible with information that is both accessible to both the public and researchers using the different tiers of data. There's a public tier data that anybody can go onto the All of Us research website and look at aggregate data to learn more about the types of questions that are being asked to participants and to see what types of responses are being used as a whole. There's more, protected data tiers where Dr. Elm, I believe. Yes, Dr. Elm, mentioned, I just wanted to make sure I was getting the name correct, that Dr. Elm mentioned, that requires a data use and registration agreement. And that gets into this a little bit more individual-based data that, you have to undergo some training and make sure that we're protecting the data of those participants. But that gives you a little bit more specific data, and that could be helpful in understanding the health experiences of people with disabilities in this case, but as well as the many other UBR groups. What's amazing about this is that participants have the option to, participate as much or as little as they want. They can engage with one survey and just provide basic general demographic information. They can provide electronic health records, biosamples, all of that, or as little of that as they want. And this is really helpful for researchers to really get an understanding of the types of experiences that people are having when it comes to their health, and really moves us away from this one-size-fits-all approach in health and research, and really get to look at the nuances of the individual and provide that precision medicine approach that, quite frankly, is long overdue. This is also, helped along by focusing on participants as partners. A lot of NIH's governance in the All of Us research program really includes participatory action research and mechanisms that are needed for participants to be involved in research. There's a whole lot of ethical, legal, and social implementations that or implications that are being done within the program. There's different committees and subgroups that have people both within the program and outside of the program that have lots of hard discussions about what is the actual impact of this research program, the questions that are being asked, the surveys, and the biomedical samples that are being collected. So what we do is we really help with some of the accessibility standards in the All of Us research program. We really push back on the program. I mean, we're not just a organization that NIH says, hey, this is what you need to do. It's a partnership. And so we have lots of conversations and ways to improve the program to make it more accessible. We push back when things are not accessible. There's been some conversations that we've had around 508 accessibility in digital media, and we've had to educate and provide, technical assistance and some of these things to really encourage that these things are available for participants to be involved in. That this doesn't extend to participants, it also extends to researchers as well. There was a period in time in which the data bench that is used by researchers was not really accessible by screen readers, and there are still some screen reading programs that are not able to utilize the workbench as a researcher. And so that's one of the things that we're working on with the program, to make sure that every researcher that wants to be able to use this can use it. We also educate researchers onto why the All of Us research program could be helpful in augmenting their research. Disability and health researchers are really protective of the data sets that they use. They like to go back to the data sets that they're very comfortable with, and it can be really hard to break them out of that comfort zone because they know that different data sets have not been inclusive in the past. So when you find the one that you're like, this is covering the data that I want to cover, why would I go to anything else? And so that's been one of the barriers that AHD has been working on, is explaining what type of data NIH has available in the All of Us research program, why it's helpful for researchers to be using that, and that the mere presence or fact that disability and health researchers are using this data set will help expand the usage of it to better meet the needs of the disability and health community. We also help expand areas for recruitment. Currently, right now, the only way you can participate in the program is if you're able to provide your own consent. This leaves out a large portion of the disability and health community. If you cannot provide consent, if you have a variety of different disabilities, intellectual and developmental disabilities, there are some aspects of that community that might not be able to provide their own consent. Progressive and degenerative disabilities like Alzheimer's and other, disabilities, mental health and substance use disabilities can all impact your ability to provide consent in the definition in the way that NIH is defining that. And so this is an area that AHD is working on very closely with NIH, so that we can include groups like that are unable to currently participate, which will then, of course, expand the number of participants that can use the All of Us research program and enroll and register, which will then expand the number of researchers that can conduct research using their data to help inform health and advanced precision medicine. We're also working on expanding to pediatric enrollment, focusing on the disability population within the pediatric population itself. And so obviously that's a big, difficult area to work on, because children can be hard to work with in general when it comes to the healthcare space, because they're not always wanting to be a part of a healthcare settings, collecting blood samples or saliva or things that can be really difficult with children. And then you add disability into the mix. That's another area that AHD is working on and expanding on, and hoping to make it a little bit easier to have a common set protocols to include that population. Other ways that we encourage the program to be more accessible is by, pushing for home visits for enrollment. Right now, a lot of things are done online, which is great and helpful for the inclusion of many different groups and organizations, but not everybody can utilize online platforms. Not everybody has access to online platforms. This disability community is a big community that's impacted by the digital divide, as well as many other communities that are trying to be reached through the NIH All of Us research program. And so by providing spaces that the disability community and others can go to actually participate, that is accessible and welcoming and trusting. So one of the ways that we're working on that is trying to, push for home visits for enrollment, so that members of the NIH community and the All of Us research program can go to the home and help enroll people into the program and collect biosamples and do all the things that you would normally have to go into a clinic for. Additionally, we're also working on a more disabilities-focused survey that's under development. We've had lots of conversations and discussions with the All of Us research program, and really pushing forward certain questions that really drill deeper into disability. Right now, the main aspect of disability as captured is through electronic health records that are provided by participants if they choose to share that information. The other is through answering the ACS 6 questions, the American Community Survey and the demographics. Right now, those are the two really primary areas where we can get like disability identifier from participants. And so by expanding to a disability specific survey that we're working on, we can get a little bit deeper into, the lived experience of disability. We also do a lot of disability sponsored photo shoots and alt tags just to really help the inclusion of people being seen, particularly with intersectionality. We are hosting an event in the next month or so with the Asian Health Coalition to get some imaging on the intersection of people with disabilities and Asian backgrounds. So I think I'll turn it back over to you, Devin, if there's anything else that you want to add, because I mean, we do so much because this is really a partnership with all of us, and we really want to make sure that, everybody feels like they're seen and included and a part of this community. So.
No, thank you, Jacob. I think you wrapped that up fairly well. I think our portion is done, so I'll head it back over to Morris.
Awesome. Thank you so much, guys. So our final speaker for today is going to be Donna Dill. Donna Dill is a board treasurer for Mobilize Waco, a disability justice coalition working towards full participation and leadership by people with disabilities in the Waco area. Donna has been a vice president at Extraco Bank since 1990. She is also a Baylor graduate and past president of the Heart of Texas Goodwill Board of Directors. Born with spina bifida, Donna was the 1967 national poster child for the March of Dimes and came to be a highly effective problem solver, self-advocate executive, traveler, and scuba diver. Donna and her husband live in a state-of-the-art, fully accessible home in Waco's Mountain View neighborhood. With that being said, thank you so much, Donna, for joining us here from Waco. We are really excited to hear what you have to say, and I will go ahead and share your PowerPoint for you.
Thank you. Well, yes, I'm here representing Mobilize Waco, and we have had a busy year. Our first major project this year was kind of reviewing the newly constructed underpass connections that connect the Waco downtown area to the Baylor area. And we started that project in the heat of the summer. It was over 100 degrees when we went out and did that. But that was our first project. Let's see. Can I advance it, or do I need you to? Oh, there we go. Yeah. That was the 100-degree heat, and you can see we found several obstacles where, the sidewalk to nowhere is one of my favorites. And we can move on. Yeah, that's more of the sidewalks. And then this is Biddy and Bose. They've been a good partner with us. And we had a big project there. Their parking lot is maybe not the most accessible, and so we were able to have an unused bike rack moved and have it converted to handicap parking with available accessible spaces, for van access and that kind of stuff. So that was another victory for us. Okay, next slide, please. And these are just some general pictures. We have had a very successful partnership with the Texas Department of Licensing and the Regulation Advisory Board. And we're working with several local work groups and metropolitan planning organizations to make sure that we have a voice in the future of Waco and just trying to make our city more accessible. Okay, next slide, please. And we are currently promoting two apps. One is the parking mobility app. It was developed by a group in Austin, and it allows you to discreetly report accessible parking violations. You take a picture with your camera, with your phone, and submit it via the app, and it will notify the violator of their parking their parking violation, and it will give them an option to reduce their ticket amount by taking education to learn why accessible parking is so important to us. And then the other app is the iAccess Life, and in that app you're able to rate, review, and research places that you find accessible. So you know, a lot of times when people with mobility handicaps are planning an outing, they have to kind of do reconnaissance before they go, send someone out to make sure that it is accessible. So hopefully this app will help people do that. So if you're wanting to try a new restaurant, you can look it up on iAccess Life and have an idea of how easy it's going to be to get there and find parking, and you know, work within the business. So so anyway, that's just that's a very brief recap of kind of what's going on with oh yes, and we have a radio show on our local NPR station. Once a month, Meg Wallace interviews someone in the disability community, and our program has been really well received. And you know, if you guys have a chance, if you like listening to podcasts, look it up and listen to it, because there's been some really fascinating people tell their stories. And so so that's my spiel on Mobilize Waco. But I would like to share my personal journey through breast cancer. I was diagnosed with breast cancer in November of 22, and so I decided to go to MD Anderson. And one of the first doctors that I dealt with was Dr. Jessica Lung, and she was the professor, or she is the professor and deputy chair of the Department of Breast Imaging. And so she asked me how my cancer was discovered, and my cancer was discovered through a routine mammogram, and because it was very small and it was undetectable by any other means. And Dr. Lung told me that in her practice, it has been very unusual to see people with disabilities diagnosed at such an early stage, which is kind of upsetting to hear. But, you know, as I thought about it and thought about the people that I know, I have a very good friend whose daughter has cerebral palsy, and she's has a very high degree of spasticity with her cerebral palsy. When she was 38, she was diagnosed with stage 4 breast cancer, and they were very, very concerned that they were going to lose her to that. And so I asked her mom, who's my friend, I said, you know, how was her cancer discovered? And she said it was discovered by one of her caregivers who was assisting her with her shower. And you know, and I just thought, wow, that's, you know, that's terrible, you know, that she should have to get to a point where someone else would notice it, that there were no preventative screening mammograms or other screenings that were available to her. And, you know, I will have to credit my primary care physician with with really staying on top of me about getting all of my proper scans and everything, and keeping up with my doctor's appointments like I need to. And I had this discussion with my brother the other day about, just the lack of access, and it's hard to decide, is it the primary care physician that is not encouraging people with disabilities to keep up with their screenings and their care, or is it the person who just says, well, this is kind of a hassle, I don't want to do it, or is it even offered? It is a hassle, and nobody likes to do that kind of stuff, but you have to be your own advocate. And I was very fortunate to have really good training from my parents on how to be my own advocate. And I will say that I have had challenges in dealing with the medical profession to make them understand the things that I am concerned about regarding my own health. And I when I was a child, I had an excellent team of doctors. I think we were lucky to. I was born in 1961. My parents were in college at Sam Houston, and so back then there were no ultrasounds. There was no warning. It was just like, we're having a baby, and like, oh wow, we had a baby, but we have a baby with lots of special needs. And in 1961, many times children with disabilities were institutionalized. And that's what the doctors encouraged my parents to do. Thank goodness they were young and naive, and they refused. And I was the first child and the first grandchild on both sides, so I was supremely spoiled. But they took me home, and we had a team of doctors in Houston that really guided us through my childhood. And but I'll tell you, when you age out of childhood care, pediatric care, as a disabled person, it is really hard to find find a doctor who will help you coordinate your care across your disability. You have to be your own advocate. And I have had I have had many good doctors, and I have had several doctors that need some sensitivity training. I am routinely asked if who takes care of me. I live independently, and I always have. I am routinely asked, if I live in a group home. Just a lot of questions that assume that my capacity to care for myself and make decisions for myself is impaired. And that is extremely frustrating. In fact, I just completed my reconstruction surgery related to my breast cancer last week, and one of my brothers drove me down and brought me home. And so when you check out, the social worker calls to make sure that you have everything that you need. And she thanked my brother for taking care of me for all these years. And I to my brother's credit, he was as offended by that statement as I was. So it's just constant education, and sometimes it is very frustrating. So I'm happy to know that there are groups out there that are trying to expand the research to include disabled individuals, and I think that is something that we want to encourage everywhere we can is do not make assumptions based on someone's, you know, labeled or unlabeled disability.
Absolutely, Donna. That was great. We absolutely love to hear about the work that you're doing with Mobilize Waco. And yeah, like Devin and Jacob have been saying this entire time, no research without us, right? Making sure that we are actually having our experiences being uplifted and seen by everyone else. We have a question for Donna in the chat first up. Do you think physical access to screening equipment is part of the problem of underdiagnosis?
Probably, because I will say that, that there have been times when I've gone into the office and it has not been easy to access the equipment. I think that the onus is on the provider to try to figure out how they can help their patient. There's there a lot of times there may be an alternative way to diagnose something that should be considered, but there's no way that you can expect patients to know that. It's really the onus is on the doctor. If someone needs a certain type of screening and there's a physical reason why they can't get it, the doctor needs to try to figure out what else they could do to get that. What if there's another way to make that diagnosis.
Absolutely. I also kind of want to redirect this question to Dr. Elm because I know just reading your bio, you've also kind of seen a lot of in provider circumstances, kind of these issues to accessibility. What does that look like from your point of view as both a social worker and now a current researcher?
Well, I have to say that Donna, what you said about the social worker who wasn't acting appropriately, I get embarrassed a lot of times by how some providers act and treat people. There's the idea that we're supposed to be moving towards cultural competency is sometimes what they call it, or cultural humility, and there's just a really long way to go. And we all have things to learn. I mess up sometimes with different things or call people the wrong gender on accident, and I think it's a lot of it is like we have to, like Donna was saying, I think sometimes we do a lot of educating, but also it can be pretty exhausting, and I'm sure a lot of you all feel that way. I think that I'm kind of going off from your question, but I think it's always good when you have allies in the room and you don't have to be that person to do that educating or advocacy, kind of again what Donna had shared about her brother. So I think those allies, just surrounding ourselves with allies, is so helpful. I should just come out and say I have ADHD, so I apologize if I didn't quite answer your question, but I'm happy to listen to it again and try again.
No, that's a great answer. Devin, Jacob, do y'all want to contribute? Oh yeah, Donna, what do you have to say?
I just like to say I don't want to pick on social workers or anything, because physicians are equally culpable. I made a decision when I started going through all of this cancer diagnosis and treatment and stuff to I have gone to all of the doctor's appointments alone. And the reason that I've done that is because many times when I have someone with me, if I take, a friend or a parent or, a family member, the physician tends to direct the conversation to that person. And, I am in charge of myself. I'm in charge of everything about me. So, and I have actually kicked a doctor out of my room before when they have repeatedly turned to my family members to discuss my my um my treatment, my course of treatment. And so I just decided that was one thing I was not going to deal with. I'll just go by myself, and they have no choice but to direct everything to me. And you know, it's I mean that's a tough thing to do, you know. But yeah, I you know, I don't want to pick on social workers because everybody does it, and it's just frustrating.
Yeah, I'd like to add to that. Sadly, a lot of that kind of extends to the fact that a lot of people who undergo healthcare training, whether it's physicians, social workers, OT, PT, you know, speaking from my experience as a, you know, being trained in OT, it's just not taught. And that's a big problem with the institutions themselves. You know, the institution themselves are failing groups that are not straight, white, and male, unfortunately. And it's a big problem that has yet to really be addressed. You know, disability education and etiquette is not really taught. Uh, Engaging with the LGBTQIA community plus is also not taught very often. Any group that's not white is also not really well taught. And if it is taught, it's for an hour-long lecture that is promptly forgotten because you move on to the next thing in healthcare. And it is a problem that is slowly being rectified by advocates, by people in the community who go to these healthcare appointments and they say, hey, I've experienced this for 30 years and you have yet to ask me about this really important fundamental aspect of my health. Why aren't you asking me about this? And most of the time it's because they just didn't know to ask. And it is a problem. And it really sucks that that onus does fall on the patient when the onus should be falling, as Donna says, onto the provider. It just isn't there yet. So.
So one of the questions, that was a great answer. One of the questions that basically our scholars and students always ask is kind of a two-part. One, how did you get to the position you're in? And two, what advice would you give to people who are looking to pursue research, who are looking to pursue advocacy as a disabled person in the field of medical research or just advocacy in general?
I can start. Mine was a string of oddly formed decisions that led me to get an English bachelor's degree and then a master's degree in higher education. And then I realized I didn't want to do that anymore. So here I am. If I were to offer any advice, I would say don't forget to be the voice for the voiceless, and that includes you as well. Use the platform that you have and the power that you wield as an individual in your community, disabled or not. And I think once we start putting, you know, ladders down for those to climb up to meet us, we'll be better off as a society in terms of advocacy. So that's all.
That's awesome. I'm engraving the question. I'm engraving your answer of be the voice for the voiceless, including yourself. I need to get that tattooed somewhere. That's wonderful.
If you do, you have to tell me.
Yeah, I mean, I really want to echo that. I think I myself didn't expect to find myself in this position. I mean, I went to school to go be a provider in, you know, in the healthcare space, and along the way, I found out that that just wasn't the place for me. I really resonated deeply with being a disability advocate, and so yes, I'm trained as a clinician, and yes, I've learned a lot of those aspects of, you know, health and healthcare. But I personally, through my own experiences, thought it was failing deeply. And so that's kind of why I got into the disability advocacy and research space instead, because I really felt like I could do more there. You know, I think the work that providers can do for patients can be really meaningful and helpful, especially on a one-on-one basis. But it doesn't always help from a community-based perspective or on a, you know, a population-based perspective, unless you're really deeply ingrained in the biomedical research side of things. But as we all know, that's really ableist and racist and just falls short. And so this really grassroots, community-based, work that AHD is really trying to do on a national basis. Kind of seems counterintuitive when I say grassroots and the same sentence of national, but I think that is one of the things that AHD is trying to do by working with community organizations and groups and really getting to the people themselves. I think it's really important, and finding your own way to get to that place if that's what you want to do. I think both Devin and I can equally say it's not really the journey that's gonna get you to where you want to go. It's you making that decision to do that, and all the things you do along the way will really just help inform that and give you a different perspective than maybe those that have been doing it for a really long time might have. So
Awesome. I want to respect everyone's time, but Dr. Elm, if you wouldn't mind answering the question, just because we know you have that unique perspective as well.
Sure. Actually, what was said really resonates with me. I actually worked in direct healthcare for 10 years, working my way through to get my undergrad degree to become a social worker. But I very similar to what was just said, I wanted to effect change on a larger scale. And so when I entered into my PhD program, my goal was to help tribal nations access data so that they could better serve their communities. And in many ways, I'm still on that trajectory, but it just has taken some twists and turns, and have found my way over to working with NIH about research data access. So that's a little bit about my journey.
Well, thank all of you for coming today. This was a super informative panel, and I know that our students are absolutely going to love having heard this, and also from having learned from all of you. Once again, I want to respect your time. To all of the people who are attending live, we've gone ahead and dropped some links in the chat, and after this webinar ends, we will send an email with links to follow all of these people and to continue to talk to them. So once again, follow Mobilize Waco, follow the American Association on Health and Disability, reach out to Dr. Elm, talk to her about all of us. And we are so grateful for y'all being here. Have a wonderful day, everyone.